Thanks, Kathy. Deborah Meyer is going to now finish our formal presentations, then we'll have the panel. Thanks.
Good morning. I've been an oncology nurse since 1975, so I've lived through all of these phases that we're talking about of where cancer care has been and where it's going. I also joined the club nobody wants to belong to 10 years ago. What I want to talk about is, in response, a lot of this data you're very familiar with about the growing numbers of survivors, but also the growing number of long-term survivors. And we are not well equipped or prepared to deal with that growing population. But more importantly, when we start talking about the costs of care, one of the issues is we worry a lot about the cost of drugs, rightfully so, and how can people afford, but in recent data that just came out, the cost of care in that middle part of the survivorship trajectory is actually where the largest amount of costs are incurred. And so when we start thinking about the continuing care component of the continuum, we really need to start thinking about how do we right-size care, as Catherine mentioned. We all know from the original report about the 4 essential components of survivorship care, and I don't think anybody is unfamiliar with them or would argue. I am going to spend most of my comments on the 4th aspect because we are paying attention and trying to move ahead, as you heard, in these other areas. And we know that in 2011, the Live Strong Foundation had the consensus meeting to try and define what those essential elements of care were. And in some recent reports and studies that are being done at GW, if anybody's here that can share more of that later on, will show that we're making some progress in delivering Tier 1 services to survivors. We've not been very successful in getting to Tier 2 and 3 for survivors so far. But again, we have a hard time really defining and describing what are these models of care. But what I really want to talk about is what I think is at the heart of some of these issues, because I was raised in the 70s in oncology where there wasn't the word survivor. And our patients, we took care of the whole patient. There wasn't hospice either. And there wasn't palliative care. We took care of the whole person till they died, and that's usually what happened. As care improved, we didn't shift our model in our mental model of taking care of the whole patient for the rest of their life. And so we really aren't in the mindset of letting go or sharing, even though all these other specialties have developed and all these other long-term and late effects have gone on. And so we almost cut out the primary care provider from day one, and we really don't think about how do we transition. We shouldn't have to be transitioning back because they shouldn't have left. And you saw the data about how many comorbid issues somebody has before they're diagnosed and then how many develop after they're diagnosed. Now, I know a lot of medical oncologists, and I know we were all trained like I was as a primary care nurse, as an internist or whatever, is how many of you are that current about managing diabetes and hypertension? I work with oncologists who may, as a favor, renew a prescription, but don't ask them to get into, higher level care, is that we are not capable of taking care of the whole person. And no one person is. And as the oncologist who mentored me said, I can't do what I do if you don't do what you do. And we all need to remember that as to who we do, manage all of that. And so there was a recent review, a literature review on the core relationship between primary care providers and oncologists. But when I use those words, I also want you to remember that most of the people delivering the care is actually nurse practitioners. And we're the ones that are going to extend and enhance the care that needs to be delivered in any model that gets delivered. And we're going to be the bridges between these issues. But the summary of the literature search is really sort of sad, and really, I think, is at the crux of us rethinking how cancer care is delivered, which is that there's poor and delayed communication between primary care providers and cancer specialists, and our patients know when there is and isn't communication. I've had patients in focus groups tell me that they're the ones that are getting pimped for information by their PCP. They come in and the PCP starts asking them questions to sort of get along with like what's going on with them. And they know that. And then there's others where they don't hear from their PCPs, and they get angry about that, feeling like they've been lost to them, and it's the PCP's lost in the trail of EHRs and electronic health records of the record being accurately reflecting who the PCP is. In our institution, for a long time, about half of them didn't even have a PCP listed, and when it wasn't always accurate. So you can see how easy it is to get out of the loop with that. The other is from the Spark study many years ago and other studies going on, oncologists think that they should be delivering this care, but primary care providers clearly are saying that they believe they have a role in this. Oftentimes patients would say they go to their primary care provider to understand the oncospeak and translate it into English. And so that there is an important role, including the decision-making, because they want their oncologist to do everything possible to manage their cancer, but they may want to go to their PCP to discuss the whole family care and everything else that's going to try and make the best decision for themselves. And they're willing to play a role. They don't want to be mini oncologists, but they really feel that they have a role and are very open to being educated about that. In one of my survivorship care plan studies, I did both focus groups and interviews with primary care providers, and they're very open saying, I don't know what to do, but if you tell me, I will do it because I want to be part of this. And that they're uncertain about the ability to do this collaboration. And so when you have this kind of discordance between what I thought you had the baby, no, I thought you had the baby kind of thing, that there's going to be some failures in handoffs and transitions, which are very important in our complicated healthcare system. Niraj showed that with his personal story. In New England Journal of Medicine, there was a wonderful cartoon that showed somebody who had a suspected tumor, and over the course of 2 weeks, it was a cartoon. I don't know if any of you saw that. For time, I didn't put it up. But it's a cartoon of how many emails, phone calls, visits, and exchanges happened between the primary care provider and all the specialists that were involved with the patient. And it ended up something like 86 in 2 weeks. And that was only some of them with the patient and the family members. So it's very complicated, and our system is not getting any simpler to do all of this. And then we've talked about models of care, and all the models that we talk about are based on risk stratification so that we know who we can safely send back with not a lot of follow-up, those who can never be sent back for total follow-up, and those in the middle. But we're missing the data on how to triage those patients. So nobody's comfortable in doing it because I don't have the solid data to say, you're that low risk, you can go back and not worry about it. You're high risk, we're never going to let you go. And so we need to capitalize on big data, and that's where some of the moonshot funding would be useful, looking at how we use big data to look at large populations to try and define in overall survivors as well as disease-specific survivors who fits into what bucket, and then creating the appropriate algorithms for that. And Kevin Effinger's in the audience, and Mary McCabe from this paper in 2013, and Larissa here is from 2017. And these are great papers, but we need to operationalize them. And until we do, we're not going to be able to expect them to be widely disseminated because nobody's going to have the confidence to do it without the backup data. So I think the challenges for this next day and a half and for the next decade is we're going to have to rethink how we deliver care, what care is needed. We cannot afford to throw all care at all people because we just can't do that, and it's not appropriate. Who needs that care, and defining that and using data to drive those decisions. Who delivers that care? And it doesn't necessarily even need to be a person delivering that care. And Catherine and I were talking about the Alexis model. Wouldn't it be nice to give every cancer patient their own Alexis? That's their disease specific, where they can then talk to it and say, you know, I'm worried about this. I dropped a brick on my toe. Does that mean my cancer comes back because it now hurts? Believe me, I've had patients that that's happened with. Or other things about monitoring patient-reported outcomes that feed back in developing systems. We know that can happen. As well as looking at not only advanced practice providers, but nurse navigators and lay navigators to extend and enhance our system, because there's not going to be enough of us to do this, but we have the expertise by which we should be informing what they do. And then where care is delivered. As we know, in the old days, it used to always be in the hospital. Then we follow the funding as far as where chemo is delivered. When it got to be outpatient, we moved to outpatient. But we all know that a lot of this is moving into the home. And how How well prepared are family members and friends going to be able to do that? And what are we going to do for the people who don't have that kind of support? And so we really need to be developing optimized functionality and use of our electronic health records as well as apps and mHealth to extend our impact in doing that. And using Catherine's slide and being a part of the Blue Ribbon panel, the whole key is accelerating progress. And that was what we were trying to do with the recommendations of Blue Ribbon. How do we get 10 years progress worth in 5? And hopefully at the end of this day and a half, we'll have that blueprint to be able to do those things. And a picture's worth 1,000 words, and survivorship does begin at diagnosis, and we do need to help people through all the phases of this care. Thank you.